one session on retinoblastoma. And all the questions will be open after the end of the presentation. And we will have all the time available for questions. So please stay with us until the end to ask your questions. And I will let Professor Martin Raphael start with the pathology program.
Thank you, Laurence. And I would like to present the follow-up of the Reference Center for the Diagnosis of Childhood Cancer in Senegal. And really, I thank the organizer to give us a possibility to present this follow-up. Zut. This project has begun in 2022 in Dhaka with a major goal to deliver a timely, accurate diagnosis for childhood cancer. And as you know, in low and middle income countries, childhood cancer became a major cause of death, with the impressive gap between high-income countries where 80% of children are cured, and in low middle income countries where 80% of cases occur with only 20% of less survival rate. This project is in accordance with the priority of WHO Global Initiative for Childhood Cancer, defined in 2018, with a target to attain 60% of survival rate by 2030. And Senegal is one of the focus countries with formal ministry engagement as part of the global initiative Cure All for Childhood Cancer in February 2021. The first step to access the right treatment of cancer is a timely, accurate diagnosis. And in sub-Saharan Africa, there was still a lot of difficulties to apply WHO criteria for cancer diagnosis because the lack of equipment, reagent, and training in complementary techniques. And with the support of the Martian Matters program of the Sanofi Foundation and the Pathology program of Emcc, we are developing a reference center for improving diagnosis. And this center is open to pediatric oncology units in Senegal, but also as a network in the West Africa sub-region and Francophone Africa countries. So the overall project goal is to develop cytological, histological, immunological, and molecular and genetics techniques to obtain the criteria defined by the WHO for cancer diagnosis. And this project will be spread in the two phases. The first phase between 2020 and 2021 concerns improvement of sample flow, patient registration and database, upgrading and of pediatric anatomy and cytopathology, and extension of telepathology, and the development of immunophenotyping and biobanking. The intermediate and second phase between 2022 and 2024 is the implementation of genetics and molecular biology platforms. So the organization of the Reference Center for Diagnosis of Childhood Cancer in Dhaka is organized as a federation between the pathology, the pediatric oncology unit, and with the coordination of a clinical research coordinator, and which is located at the Aristide Le Dantec teaching hospital. And there is a connection between three labs. The first lab, which is set in Aristide Le Dantec teaching hospital, concerns the cytology, cytochemistry, and we develop at the University Cheikh Anta Diop molecular biology and cytogenetics. the hematology lab in Dhaka Teaching Hospital developed the flow cytometry with immunophenotyping and biobanking for live cell and serum. And there is a development of the oncopediatric pathology at the university unit, and histology, immunohistochemistry, and tissue sample biobanking. The result of the first phase between 2020 and 2021 is quite encouraging. There is an agreement of cooperation signed between the Faculty of Medicine and the Emcc in 2021. And there is really an improvement of diagnosis and second opinion with telepathology using a platform which is well known, which is a platform, and we can get second opinion from different experts in pathology and in childhood cancer. Immunophenotyping is developed by flow cytometry and immunohistochemistry. And biobanking for tissue begin, and there is 74 samples which are registered. 115 patients are registered in RedCap software in 8 databases. This database concerns acute leukemia with 41 patients, non-Hodgkin lymphoma, 11 patients, Hodgkin lymphoma, 3 patients, nephroblastoma, 23, and neuroblastoma for 13 patients, retinoblastoma, 19 patients, and rhabdomyosarcoma, 16 patients. There is also rare tumors, which are 36, and among them, we can notice there is germinal tumors. What we have to notice is 10% of samples are referred from African foreign countries, Gambia, Mauritania, Guinea-Conakry, Guinea-Bissau, and Mali. And this is important because this center is organized as a part of a network with the foreign countries. And what is the evolution and the sustainability of the reference center? And as I told you, the reference center is a part of a network with increase of referred sample for complementary techniques, diagnosis, and second opinion. The research project concerning clinical, epidemiologic, and basic science topics are done with the beginning of MD and PhD thesis. And there is also an educational program which is developed along the and virtual courses, which is e-learning, and with workshop and training courses. The first workshop for immunohistochemistry was developed in March 2021, and other presential educational meetings are postponed due to the pandemic. The organization of the university diploma, such as oncopediatric surgical pathology or complementary new techniques, immunological techniques, molecular and genomic, will be organized in the future. So I would like to thank and to present you people who are involved in this reference center. Professor Awa Touré and Professor Sherif Dial. Awa Touré is a hematologist and Sherif Dial is oncopediatric pathologist, and they are the coordinator of the center in Dhaka. And Dr. Fatou Bintou Diaye was a pediatric oncology unit. She is the chief of this pediatric oncology unit. And Fatimata Bintou Sall developed the database. Abibatou Sall, and you will listen to talk, developed flow cytometry in Dhaka Hospital, and Makou Hagaji, who will present us the implementation of cytogenetics and molecular biology, who developed these complementary techniques. And I would like also to thank Professor Aurore Coulon and Dr. Elisabeth Auberger, who are very active in second Omicron using telepathology, and of course, François Desbrand, who is the head of Maréchal Mater Childhood, because without this program, we could not organize this. So thank you very much for listening us. And before the second talk on the center, I would like to inform you about the launch of a Cancer Control Francophone edition. And this is edition, the first one edition in 2021 with Sanofi Espoir Foundation. And that edition will be launched the 20th of November, which is a Children's Day. And 7 articles about the activities in Dhaka will complete this talk. So thank you very much. And I think that Professor Abitsal will present you the flow cytometry and immunophenotyping in Dalal Jamm Hospital. So I would like to ask, yes.
Okay, good.
Thank you, Mrs. Raphael. I would like to thank first the organizer of this webinar, especially Dr. Laurence Desjardins, who gave me the opportunity to present the development and the implementation of immunophenotyping by flow cytometry in hematopoietic malignancies in Dalal Jamm Hospital as a part, of course, of the Imcc pathology program during this London Global Cancer Week. Sorry. So as we know, the diagnosis of hematopoietic tumors has long been based on clinic and morphology. For acute leukemia, we had the French-American British classification, which is still relevant today in some cases. And for lymphomas, several anatomo-clinical classifications have been existed. Over the past 20 years, there has been the emergence of a unique classification, that of World Health Organization, which is revised every 8 years. This classification, based on a diagnosis strategy, includes different arguments: cytogenetic arguments, clinic and morphology first, and also phenotype, cytogenetic, and molecular biology arguments. In low-income countries, and particularly in Africa, the lack of technical facilities and the experienced staff make it difficult or even impossible to comply to the WHO recommendation. And our country, Senegal, is not an exception to this category. So since a few months, the introduction of routine immunophenotyping has brought considerable diagnosis precision. So today, we're sharing our results based on a study population consisting of patients referred to our facility for immunophenotyping. We studied different parameters, epidemiological parameters, such as age, sex, geographical origin, and the clinical data are provided by attending physician. Concerning hematological parameters, we studied the blood count first with Sysmex devices, or bone marrow cytology with biochemical staining if needed. And for immunophenotyping, we use two types of Becton Dickinson cytometer. We use first of all caliber 4 colors, and recently we work with the Faxlyrics 8 color. What about our results? We received 124 patients. Among them, there were 61 cases of leukemia, including 30 children and 31 adults. And as expected, acute lymphoid leukemia were predominant in children, while acute myeloid leukemia was predominant in adults. And we have one case of mixed phenotype of acute leukemia. On the other hand, 63 cases of lymphoproliferative disorders have been diagnosed, all adults, of course, and we have the predominance of B lymphoproliferative disorders with 48 cases. The mean age of children of acute leukemia was 11 years old, and the sex ratio was 1.7. And flow cytometry allowed us to determine the lineage which is affected, and we have more B-ELL, 16 B-ELL, and only one T-ELL, which was the T4-ELL. So this is an example of common ELL or B2-ELL with the positivity of B marker and the positivity of CD10, while IgM and surface immunoglobulin were negative. For acute leukemia in adults, we observed a slight predominance of men with a sex ratio with 1.21, and the mean age was 43 years old. And the flow cytometry allowed us to correct the diagnosis of ELL into AML0. And for the mixed phenotype of acute leukemia, we have positivity of myeloid markers. Cytoplasmic MPO was positive, and also the positivity of B markers such as CD19 and CD22. Regarding the B lymphoproliferative disorder, we found a majority of chronic lymphoid leukemia with a hematocrit scoring between 4 and 5. We have 2 cases of marginal zone lymphoma, 2 cases of splenic lymphoma with villus lymphocytic with the positivity of CD11C, and 2 cases of plasma cell leukemia. So this is an example of the markers of plasma cell leukemia with the expression of CD138 and CD38, the lack of CD19, and also the aberrant expression of CD56. Regarding T lymphoproliferative disorders, Sézary syndrome will retain in 6 cases due to the ratio CD4 on CD8 greater than 10. And we have 6 cases of acute T leukemia. And this is an example of the results of acute T leukemia with the strong expression of the CD25, and here we have the lack of CD7. So in conclusion, we can say that implementation of immunophenotyping in Senegal has been a real challenge, both technically and financially. And we are aware that it is an essential tool for diagnosis, classification, as well as the monitoring of hematopoietic tumors. So what's next? First of all, we must ensure the sustainability of this activity and then move forward the implementation of the cytogenetic establishment of molecular biology for diagnosis accuracy and effectiveness and efficiency of patient care. And I'm sure that my colleague, Professor Gachi, will talk in detail about this cytogenetic within the framework of the reference-centered diagnosis of childhood cancer in Senegal. I would like to end my talk by thanking my mentors, Professor Martin Raphael, Vice President of Imcc, Professor Awa Touré from Dhaka University, and a big thank you to Dr. Dan Milner, President of ICP, and Daniel Bitton from Becton Dickinson. I don't forget all my colleagues in Bislett Hospital, Daladiam Hospital in Senegal, and also in Dhaka University. Thank you all. Merci.
So can you stop sharing your screen so Dr. Gadji can start now? Dr. Gadji is not connected. Okay.
Of course, I'm connected.
I'm okay, good.
It's a very, we are in the morning. It's a 3:30 in the morning here, but I'm trying. And thank you very much, Abby, to introduce the cytogenetics. And I think this will help a lot. And let's share my presentation or first. I think it's that one. Yeah. So I think I can start.
Yes.
Okay, thank you so much. At the beginning of my talk, I want first to thank the organizer for inviting me. And so I will try to show you today how we are starting to introduce cytogenetics and molecular biology in this project. From Mendel, we know the law of genetics. And from Watson, we know the structure of DNA molecule. But from Bovary, what we know is cancer is a DNA pathology. In other words, cancer is a genetic disease. Of course, in any cancer, genetics and genomic abnormalities are present, and there are either initiator, either driver, either passenger mutation. That's what we call genomic instability. Genomic instability is the driving force of any cancer. Then, for accurate diagnosis of any cancer, we need cytogenetics and molecular biology. To better understand cytogenetics and molecular biology, let's go back to DNA molecule. If you study disease at the chromosome level, we are doing conventional cytogenetics. If you go further at the loci or the gene level, you are doing molecular cytogenetics. And further, if you go to the DNA sequence, you are doing molecular biology or genetic or molecular genetics. So the most common child cancer are worldwide are brain tumors and neuroblastoma, followed by sarcoma, leukemia, and nephroblastoma. That's why our goal in this project is to set up a diagnostic laboratory for chromosomal, genetic, and molecular abnormality in childhood cancer with a view to targeted molecular therapy. So how are we going to process how we'll do that? We'll take into account what was already achieved by our colleagues in Senegal, in which we know that 175 patients, 6 children was involved, was recorded, and in which the median age is around 6 years, from 2 to 17 years. The diagnosis were accurately performed for 167 patients. So, but the diagnosis use only cytology, histology, and immunohistochemistry, and of course, some tumoral biomarkers, but they was really accurate. From that, we start to introduce the genetics and molecular biology. But if you look at carefully what we have child cancer distribution in Senegal, but the most common are ALL, acute lymphoblastic leukemia, followed by nephroblastoma, retinoblastoma, retinoblastoma. I put 2 times nephroblastoma, sorry, it's neuroblastoma, nephroblastoma, and retinoblastoma. That's why for this first step of this project, we want to focus on those diseases, on those cancers, to investigate those, to set up the lab, and to move on for others cancer. So what we're going to do exactly? From the clinical data, of course, we'll do the sampling. And from the sampling, we'll do direct harvesting and cell culture. By doing so, we can do the karyotyping, and we'll introduce FISH technique, the molecular cytogenetics, to investigate imbalance or copy number variation of the genes. So just a quick example here is, from the sampling, we'll do direct harvesting, and meanwhile, we'll perform cell culture, and these following the cytogenetics rules, cell culture, harvesting, spreading on a slide, doing cell chromosome binding. Let's say we'll go to do G binding and do the karyotype. And from that, what we're going to add is the FISH technique. FISH is fluorescence in situ hybridization that use labeled probe, fluorescence probe, that target specific genes or target specific loci or locus. And so you can, from FISH, determine the copy number variation of a gene or a copy number variation of any locus. But further, you can see translocation or deletion of the genes. And that's why we'll start with FISH in the molecular cytogenetics. And just what we'll, as I mentioned previously, we're going to focus on those diseases like retinoblastoma, nephroblastoma, Burkitt lymphoma, and acute leukemia. And we use several probes. Those probes to do FISH. This list is not exhaustive. Maybe we'll add others probe, but mainly we'll focus on those diseases and use those probes, devices probe mostly, and to investigate chromosomal abnormality in those targeted diseases. And I'm going to show you some results that we have so far. Here, an example of metaphases with G bonding, and you see very well the bonding is really accurate, very, very clear, and very easy to karyotype. Easily we can recognize chromosome. Here, the chromosome 14, an example, chromosome 17, here the chromosome 1, etc. That part is really set up in the lab. So we use also FISH. We already established this technique in the lab. First, we did it with the BCR-ABL by using probe, the BCR probe in green, spectrum green, and the ABL probe in spectrum orange. And here an example in CML. As we know, translocation between chromosome 22 and 9 is the biomarker for diagnosis of CML. And what we have here, an example here, we have 2 ABL here in spectrum orange and 2 BCR in spectrum green, really separate, no translocation. But in this nucleus, what we have, 1 BCR, 1 ABL, and we have the translocation. Mix of green and red gives you the yellow color. And this is what we call the major BCR. The other one, we have 1 ABL, 1 BCR here, and we have those 2 chromosomes involved in this translocation, the yellow signals, that we call the minor breakpoint. And that's the first step that we did by setting up the fish technique in the lab. We move forward, and in myeloma here, we did another study in myeloma in which here we have the plasma cells, the cytology, and we use the probe, the one for P53. You know, P53 is a biomarker of myeloma. P53 in spectrum orange, and we use the centromeres of chromosome 17 as a control in spectrum green. And here in this myeloma cell, you can see we can see the two P53 genes and the two centromere genes really separate. But the other one, we have is two centromere of chromosome 17, but we have only one signal of chromosome of P53 genes. That means the other genes is deleted, one deletion of P53. Of course, just to mention, P53 is located in chromosome 17. And by performing the copy number variation of P53, the guardian of the genomes, we have to use the centromere of chromosome 17 as a control and use the target gene P53 to check if we have one copy or two, or sometimes we lost both copy. Another example here that I'm going to show is in a child that we investigate the developmental sex disorder using centromere of chromosome X in the spectrum green by fish and chromosome Y in the spectrum orange to see if in this child there is chromosome X and Y. And as you can see here very clearly, we have chromosome X and chromosome Y in all the nuclei. And now from this beginning, what we expect to do? At the beginning of this project, all the diagnosis was made by using cytology, histology, of course, clinical data, immunophenotyping by Sister Abby, and immunohistochemistry by Professor Ja. Now what we want to complete the investigation of child cancer in Senegal is to introduce the cytogenetics, conventional cytogenetics and molecular cytogenetics, and further the molecular biology to make sure that any cancer in Senegal will be accurately diagnosed to better treat those child. That means what? Karyotyping, fish investigation for sample for targeted therapy will help us to set up the lab and run this routine lab of cytogenetics. This will pave the way of setting a genetics and molecular lab to achieve a complete diagnosis of cancer in Senegal. That will also improve treatment by introducing targeted molecular therapy for a complete remission of sick children. Of course, by moving forward in the next few years, may we set up, of course, an academic education program for students. We need to teach students how to do cytogenetics and how to do molecular biology. And I will end this talk to say, what we want really is to improve diagnosis and treatment of cancer in Senegal, for sick children in Senegal, and of course, for Africa or in Francophone Africa, in the hope to see them smiling again. We want to bring smile to our sick children. So I would like to finish this talk by thanking all the funding agency, Foundation Sanofi Espoir, AMCC, and CRDCE. Thank you so much also to Martin Raphael for inviting me to give this talk. Thank you so much.
Thank you very much, Dr. Gajdi. So now we have finished with the pathology presentation, and I will let Dr. Alexis continue with the palliative care session.
It's not Sabine Perrier-Bonnet?
Oh, Sabine, okay. Sabine, sorry. We can start with this presentation from Sabine. Excuse me, Sabine.
I tried, sorry.
I let you speak.
Yes, good morning, everybody. I tried to find my PowerPoint. Sorry.
On le voit, c'est bon.
On le voit. Il est affiché.
Okay, thank you very much. I'm pleased to present you the one part of the palliative care and pain control program with Amcc through the creation of the Forum Palliative. We call that palliative platform, we can say, created in June 2017 for increase relation between all the actors and association in the field of pain and palliative control. So the main objective is to support the creation of reference centers and support training for the management of pain and pain control and palliative care. So there is a website called Forum Palliative, and the founder of this program, the platform, is the Pierre Fabre Foundation, a foundation that I will call later on in France. And the responsible is Dr. Laure Coppel, working in Paris in Diaconess Hospital, and Dr. Alexis Bourneau, who is working to Institut Curie, also in Paris, and myself, who is in charge to do the updating and animation of this forum. I would like to remember you the context of the two complementary partners, that's Alliance Mondiale contre le Cancer, that you know, it's to help improve cancer in French-speaking country in Africa, and the founders is Pierre Fabre Foundation, who try to help all the countries who need emerging or developing countries to have access both in quality and also in volume in healthcare, and more especially for drugs, essential drugs defined by the WHO. And this is the picture of the foundation based in the south of France. And you can read the mission statement with a very, very important humanitarian goal made by this foundation. What is the platform, the Forum Palliative, we call it in French? It's a forum for exchanging experience of palliative care and pain control in French-speaking Africa. And you can see the picture of this forum, where you can have different topics for welcoming the people who want to use this Forum Palliative. And in the welcoming message, we just explain that we are happy to welcome all the people who want to learn about palliative care, who want to share information. And from Montpellier, that's my town, to Dhaka or Bamako or where Kigali in Rwanda, we are together to share pain management and palliative care program. So in this, for who are this platform? It's for all the doctors, nurses, health workers, and all the people who need to have more information, more documents about supportive and palliative care. And it's also for students and all the people who want to help the palliative care. And in this website, you have the modalities. Is simple. It's a free website. You can be registered for free, and you can become a active member without problem. And this was very useful from the beginning for us to share information and to be able to communicate with all the French-speaking Africa country. And you will see some on the slide, some statistics. There is at the moment 244 messages, and with different topics I will speak about later. And we have also today 88 members really active for this forum and to share the information. And I just would like to share with you the interactive links. It's about the first national program of palliative care voted in Benin, French-speaking countries, sent by the Dr. Antelme Akpopan in 1918. That was the first program voted by the president of this country. Then on this forum, in this platform, you have some results. It's a well-recognized reference in Africa. And for looking after this forum, it's around 100 hours per year of following, of contact. And this is sent, all the information and the contact, regular contact is sent with around 280 regular people with good mails. And for communication, what is important is to see the way we share information, we share documents, updating documents, the dates of Congress, manifestation, and other news about pain control and palliative care. We are also a permanent contact with the other association about palliative care, north or south. And every month we update information, and especially the listing of people, the mail address, because you know we have often some change because of a virus or things like that. So we are very, very careful for the listing. And through the Amcc, the Alliance Mondiale contre le Cancer network, we try to shuttle form within the association to promote the information. So there is at the moment 11 different topics on this forum, and you will see on these slides the fact that you have on your left, you have all the title of the topics, and then on the right, you have the last document we share with all the health staff with the number of you that can show you the way that this forum is, this platform is very well used from people in Africa. And this is quite very, very important to see that we are access to drugs, but we speak about palliative care in Africa. We speak about end of life in Africa. So we have a lot of different topics, and have other topics more for resources, information. We share the information of our founder, the Pierre Fabre Foundation, with the annual reports. And we have also a gallery of photo and some publications, and also more difficult but very important, the testimonials information. And since 2020, with the COVID pandemic, we start also to share information about this pandemic, and for example, how to make a mask, the fact of chronic disease and palliative care through the situation of COVID. And this is just to be adapted of the situation. And then, as Professor Martin Raphael told you, we have also this information. This information I will give now, the last news about the new cancer publication for French-speaking cancer professional in World Children's Day. That's in a few days, the 20th November. And this is a very good way that we have cancer control francophone can be accessed and download for free. And you will find it after the 20th November. And what is very important is this is over 130 authors from francophone developing countries, such all the West Africa, Senegal, Mali, but also from North Africa, Morocco, and also Central Africa as Cameroon and Congo. And then for action and project for 2022, it will be for the platform forum in a pursuit of the collaboration with our partners that can be WHO, the French and African Association in Africa. And then we will continue to updating this platform because it's very useful for sharing information and project. And we hope to increase the people who use this platform, and we will expect to be more new and more useful for everybody in Africa. And now I just want to thank you for your interest, and I leave the room for Dr. Alexis Burneau, who will speak about the future project of the Imcc palliative care program and also achievement for this. Thank you very much.
Good morning. It's okay?
C'est bon.
So good morning, and thank you very much for your invitation. I'm head in palliative care unit in Institut Curie and in Paris, and work in Emcc section palliative care. So since the 1st October, everywhere in the world, on the wall, we can see that James Bond tells us that there is no time to die. For people living in Africa, sure, it's wrong. It's wrong because the time to die is very long, very, very long when you have no palliative care, no good painkillers, no morphine. And on this slide, coming from The Economist in 2015, 15, you can see the different countries with a quality of death index, so good in blue and bad in white. So we can see that in West Africa, the quality of death or the end of the life is very difficult because all is missing. In 2015, by Human Rights Watch, the estimation is that 912,000 people, including 214,000 children, need palliative care in Francophone Africa each year. The rate of over 75 is expected to more than double in this region by 2050. 16 out of 20 countries in Francophone Africa have no health services offering palliative care. And in comparison, all English-speaking African countries, except Liberia, Mauritius, and Seychelles, have at least some palliative care services. In Africa, palliative care is often insufficient, and an estimated 40 million people need palliative care each year, 78% of whom live in low and middle income countries. And globally, only about 40% of people in need of palliative care currently receive it. Morphine, the best and cheap painkillers, is available for less than 5% of people who die each year. And 16 of 20 countries in Francophone Africa have no health professionals specializing in palliative care, focus on pain management and improving quality of life. The World Health Organization show by 194 member states in 2019 that funding for palliative care was provided in 68% of countries, but only 40% of countries indicated that they could meet at least half of the needs. World Health Organization shows that 75% of the people in the world do not have access to painkillers, good painkillers like morphine. And the International Narcotics Control Board show in 2018 that 79% of the world's population, mainly in low and middle income countries, consume only 30% of the total amount of morphine used in the management of pain and suffering. That's 1% of the 388 tons of morphine manufactured worldwide. Opioid, painkillers for neuropathic pain in cancer coming from Europe are unavailable because too expensive for African people. And morphine syrup is not present in most of the countries. Jeune Afrique, a newspaper in West Africa in 2017, shows that in Africa, the concept of palliative care is almost non-existent. So it's why Alliance Mondiale contre le Cancer, Imcc, humbly try to help people to share, to develop palliative care and palliative culture. But the barriers to the dissemination of palliative care are important. Why? Because the lack of awareness among policymakers, healthcare professionals, and general public. Because there are cultural and social barriers, misconceptions about palliative care, and of course, fear of morphine, fear of potential abuse. It's why Alliance Mondiale contre le Cancer tried to team up with different colleagues to improve our power to help these our colleagues in West Africa. So we developed Alliance and we signed agreements with Fédération Francophone Internationale of Palliative Care, with the Comprehensive Cancer Center Institut Curie in France, with Supportive Care Association in France, and the help of Pierre Fabre Foundation. The first help was to support Hospice Africa Uganda, built by Anne Merriman. So in Uganda, they receive people, nurses, doctors, caregivers for a training for 5 weeks to train palliative care and to have a real experience with patients to show how they do the morphine syrup and how it's possible to practice palliative care cheaper. The second thing is to help Hospice Africa France support. Hospice Africa France funding Francophone section of Hospice Africa Uganda for advice to the importation of soluble morphine with palliative care development assistance, government actions. 4 countries are support to import morphine powders: Cameroon, Congo, Senegal, Benin, and 5 countries support in palliative care: Burkina Faso, Burundi, Congo, Benin, and Cameroon. The mission of Emcc palliative care is, of course, to train palliative care and to help to train for our colleagues, and to have a sensitization of local authorities and advocacy for access to morphine, because morphine is missing. Development of a continuing education program in palliative care and pain management with the help of volunteers, African medical teams. A significant financial support was provided by the Hospice Africa France, support to Hospice Africa Uganda with the sending of multi-professional teams, and financing the sending of doctors and nurses for training at Hospice Africa Uganda. And I was proud to be one of these teachers a few years ago. Another part of our work is to help our colleagues to develop a palliative care congress, where it is the time to share experience and to improve our quality of work. And we gave our help to build this congress in Abidjan in 2013, in Brazzaville in 2016, and in Cotonou in 2017. Of course, we developed Palliative Forum with the wonderful help of Sabine Perrier-Bonnet, who called just before. And we team up with the International Federation of Palliative Care with different programs in Benin, Cameroon, and Senegal for all these topics. What is the next project? The next project is to help our colleagues in Dhaka. We would like to help to develop a palliative care unit in Joliot-Curie Hospital after a meeting with Dr. Gay. And for that, we signed an agreement between Alliance Mondiale contre le Cancer, Institut Curie, and Francophone Federation of Palliative Care, and C3 Medical to build this palliative care unit, to help them to have a university diploma in palliative care, and to continue the promotion of morphine and its distribution to the public authorities. So C3 Medical help us because they meet president of university and the Minister of Health. Of course, we cannot work alone because the Emcc is too small and the project is huge, but we can be contagious, and it's why we continue to develop this program. So thank you for your attention.
Thank you very much, Alexis. So now we will continue with the presentations on retinoblastoma. Karim, can you share your screen? Wonderful.
Ton micro est fermé.
Hello, can you hear me?
Yes. Perfect.
Thank you. Good morning, Laurence, and thanks to all the organizers for this invitation to this session on retinoblastoma. So I will present you how we implement the retinoblastoma program in sub-Saharan Africa during COVID-19 pandemic. So this presentation is about the Imcc retinoblastoma program, which is a 10-year program. And the Imcc, this program of Imcc is led by a team with Laurence Desjardins, Pascal Sirignano, and Pierre, who are in Paris, and also some colleagues from Bamako, Fatoumata Sila and Fousseini Traoré, and Karim Hassani, who is presenting now, who is in Kinshasa. So before 2019, Imcc began to implement some retinoblastoma programs. So since 2011, and the retinoblastoma program supported early diagnosis and access to treatment and rehabilitation of children in French-speaking countries in Africa. So these retinoblastoma programs began in Bamako, in Mali, then in Côte d'Ivoire, in Congo, in Senegal, and in Madagascar. So in all those 5 countries, different successive programs was implemented with the help of some donors and partners like GFAOP, Curie Institute, My Child Matters, and some other partners. And it was possible to show that it was possible to cure more than 80% of children, like in this paper published by Fousseini Traoré in Bamako. We show that 87% of children can be cured when presented early. It means unilateral intraocular retinoblastoma. But also this paper showed that we still need to work on early diagnosis because only 58% of children arrived. 58% of children arrived at a curable stage. So what is the retinoblastoma program 2019-2028? It is about to extend the support first to the 5 initial countries, and then to extend the support to all French-speaking sub-Saharan countries and some English and Portuguese-speaking countries. And these countries will hold like 1,100 new retinoblastoma cases, expected cases a year. So this is the new retinoblastoma program. And this retinoblastoma is implemented by Imcc in partnership with Curie Institute and GFAOP, financed by a familial Swiss foundation. And this retinoblastoma program was launched in June 2019. So as we say, the objective is in 10 years to cure more than 70% of expected cases. How? First, we have this chance to have an international steering committee. And the most important thing is to help people, local teams to implement early diagnosis multi-year plans, to train people, especially ophthalmologists, ocular prosthetists, pathologists, and other health professionals who are involved in the retinoblastoma management, to have better access of treatment, and also to provide equipment like laser, like fundus camera that will allow people to do conservative management in case of bilateral retinoblastoma, to also help people to better have the registration of data, because all that we are doing cannot be monitored with good quality data, and also to advocate to reduce the costs for parents. As you may know that in Africa, in different locations, it's for parents to pay. It is for parents to pay for the hospital cost for their children having cancers and retinoblastoma also. So we need to advocate also to help people to advocate, to help local teams to advocate to reduce the costs for the parents. So in summary, the retinoblastoma program is ambitious. It is an ambitious 10-year program, which will bring the cure rates in less than 20% in 2019 to more than 70% in 2028. And local actors are the key of the success, as we said, with training and equipment, early diagnosis and referral pathway, and also to enhance advocacy. And this retinoblastoma program was launched in June 2019, but the pandemic came only 6 months after and is last now for 2 years, with lockdowns, mass gathering banned, and borders and interprovincial movements also are reduced. So this is a very important challenge. That's why we wanted to present and discuss about it today. So what exactly we experienced during this implementation of the 2 years implementation of the retinoblastoma program? So all the training and the delivery of equipment was delayed. So this gave a kind of latency in this aspect of the implementation, and the different activities, early diagnosis activities, and also the referral pathways was really put in difficulties because everything was delayed, referral pathway disrupted, and this had a consequences like to increase the late presentation, and also advocacy to was really difficult because that the intention of the health system went somewhere else. It means for the pandemic, and also the population is experiencing the poverty that is increasing in the population for now. So this will also increase the rate of abandonment in the patients that will arrive at the hospital. They will experience the abandonment because the parents are still the one to continue to pay for their treatment. So where are we now for this retinoblastoma program? Here is the place where we were in 2019, but we were able now today to have partnership with all those countries. So we came from 5 teams, now we are to 19 teams, and we hope that in 2022 we will be with 24 teams. So, and we hope that we will continue to implement the retinoblastoma program and to continue to build partnership with different other teams, continue to try to do training for the teams and to give equipment as soon as we can, as the pandemic will allow us, and since we recruit more and more teams, and to continue to support for the data and registration and the tracking of all cases with our partners, specifically with GFAP. So this is a table to show what we should do in the left and what we did in the right. So for example, mission coming from France was planned, but all those missions was canceled. So we replaced it with regular contacts with teams by Zoom or other tools like Teams. Also, we had some mission. I had some mission with other teams coming from Bamako. We had some mission going here and there in Africa to continue to support implementation of the program. So we had a planned physical meeting with teams, and for this opportunity to deliver also some equipment, but this was postponed many times. But we had the opportunity also to do a web conference discussion with retinoblastoma challenging case. Now doing it in RBNet website. So this is a very good achievement, because now we can have French-speaking countries also in RBNet. Webinar, we did a webinar in May. This webinar was able to bring 19 teams treating retinoblastoma in sub-Saharan Africa on the same meeting and discuss about the challenges. And these 90 teams have like 783 expected cases of retinoblastoma. So it was a very interesting place to discuss the challenges that we are facing. We were also able to organize a physical meeting in Senegal. It has been now 2 months. So this is also a very important achievement. We did, even though we are during the pandemic, and also we think to do another physical meeting for English-speaking countries in March, just prior to SIOP Africa meeting. Early diagnosis activities was delayed, and the increase of poverty is something real on the ground. So although we had this pandemic, we were able to launch some early diagnosis activities in some countries. And we thought that it was very important to have additional funding to finance and support some families, especially for them who arrive, for the families who will arrive at the early stage. We thought that it was very important to support their financial costs. And some training was postponed, but training was also able to be made in Bamako, in Dhaka very soon, and in Accra also very soon. So what was the lesson learned and what are the perspectives? So the pandemic had a negative impact on retinoblastoma and on pediatric cancer in sub-Saharan Africa. We thought that, we understood that global effort and partners' effort plus local effort to develop possible solutions is very important and is dynamic and synergistic. Local actors' innovation capacity is visible because we can see the example of RBNet. We can see the example of Kenya. We want to implement online training for early diagnosis. And we can see also the implementation of intra-arterial chemotherapy in Ghana and in Kenya during the pandemic. Imcc, being a learning organism, thinks that it is very important to continue to benefit and to help to optimize positive outcomes. And we can ask this question, is it still possible to reach the objective of more than 70% rate of expected cases of retinoblastoma in 2028? The answer is yes, because we have good reasons to continue to think that it is possible. So in this, with this slide, I will say only thank you to everybody, to all the people who attend this meeting, and to all the doctors who are treating retinoblastoma and all pediatric cancers in Africa. Thank you.
Thank you very much, Karim. Now, who is next, Karim? Who is going to speak next?
I think that it should be Dr. Vera Esuman or Dr. Jambi, but I think Dr. Vera Esuman is here. I don't know if Dr. Jambi is around.
Okay. I don't see Dr. Jambi. So good. Can you share your screen?
Yes, please.
I'm also here. Thank you.
Okay, good. Very good. Sorry, I didn't see you.
One moment, please.
We can see your screen.
It's okay.
Yes, okay. Okay. All right. So good morning, everyone. I think I just realized my camera cannot be picked by the Zoom, so I'm presenting without my photo being seen. And I'm presenting on the National Retinoblastoma Strategy in Ghana. Where are we now? This presentation is done on behalf of the retinoblastoma team in Ghana. I have no disclosures to make. And this presentation will cover the need for the establishment of the strategy, the goals and objectives, achievements so far, and the next steps. Ghana is a small country in the West African sub-region with a population of about 30.4 million people and a birth rate of about 800,000 children per year. It is a low middle income country. and it shares in the burden of retinoblastoma worldwide. In Ghana, retinoblastoma is the commonest ocular tumor in all ages, and it is the third commonest childhood malignancy after lymphomas and leukemias. From reported cases from general ophthalmologists in peripheral eye clinics, it is estimated that about 69 cases are seen yearly. Anecdotally, the overall survival is less than 50% currently, and there's no center that provides comprehensive management of retinoblastoma. There are no national guidelines, and funding has been a challenge until yesterday, and I will explain later. So the journey started in 2009 when we had reviewed the data for 23 children who presented with retinoblastoma in 2004 and 2005, over 20 months. At the time of the review, it came to light that only about 30% were alive or coming for follow-up. This set us thinking, and we started planning for seeking for help. This was further reinforced by the plight of two children who actually represent the plight of many children in my country with retinoblastoma. So Elo had bilateral retinoblastoma diagnosed at the age of 7 months, had one eye removed, but we were not in a position to provide focal treatment for the second eye. So he had to go to India. Unfortunately, due to lack of funding, he spent over 4 years in India with his mother and came back after 5 years of age. MY, who was a female, had bilateral RV, diagnosed at age 5 months in 2012. She had enucleation in one eye, but could not afford treatment abroad for a group B tumor, a solitary tumor in the second eye. She lost the second eye to enucleation and got enrolled in the school for the blind at the age of 5 years. But she died 6 months later from a trilateral retinoblastoma and CNS complications, a condition that could not be picked up later in the years due to lack of funds for follow-up and unavailability of full complement of treatment. In fact, MY's case then pushed us in 2017 because the death occurred in 2017, and it pushed us to seek for help. So the journey then restarted in 2017 when I had to seek for help from the Himalayan Cataract Project to attend the One Retinoblastoma World Conference in Washington. And there, the pediatric oncologist and I started the networking for this strategy. We purpose to establish a comprehensive and sustainable national strategy for retinoblastoma management in Ghana, with the goals of improving on the medical care of children with retinoblastoma nationwide, mobilize resources for the management, conduct collaborative research that will improve on survival, and underpin it with monitoring and evaluation. We're hoping for survival, improvement in survival up to 80% in 5 years when the strategy is fully established. So what are some of the major achievements so far? Team development, retinoblastoma care team has been established in the main teaching hospital. There is an interim national steering committee overseeing the establishment of the strategy. A draft national strategy was developed and has recently been looked at our national stakeholder meeting, which was held in August 2021, where the draft document was reviewed and revised and is currently being worked on to finalize it so that the ministry can start implementation next year. There has also been establishment of new treatments and services, focal and local treatments, and also training ocular pathology. Stakeholder engagement at both local and international levels have been going on the past 2 to 3 years with the Ministry of Health, Ghana Health Service, and the management teams in the major teaching hospitals in the country, and all the eye care professional societies being engaged in the need and for the establishment of the strategy. Capacity building, training of frontline health workers on early detection has been going on. And with the kind support of Amcc and World Child Cancer, we have been training frontline workers in both early warning signs and symptoms of childhood cancers, including retinoblastoma, and over 1,500 workers have been trained so far. And currently work is going on with the support of this. We are moving on to the next phase where these frontline workers will be trained with the use of arc light ophthalmoscope. And this is also being supported by Amcc and World Child Cancer, and as well as Rotary clubs in Ghana and Germany, who are also providing arc light ophthalmoscopes and training so that we can cover a greater part of the country. In addition, these Rotary clubs have helped us to establish a USSD code and an app for referral by frontline workers. And training is just about starting next month, and then we are hoping to implement it fully next year. Training of personnel in ocular oncology and retinoblastoma pathology has taken place and is still ongoing. And this has taken place in major retinoblastoma centers in North America. An interventional radiologist was trained in India in 2018 for intraarterial chemotherapy and has since been working and implementing this back home. A general ophthalmologist also was sent to Beijing Children's Hospital for training in retinoblastoma pathology and ocular pathology generally in 2019 and 2020. And he is also helping us with this strategy. Now we are able to offer all forms of focal treatment, lasers, cryotherapy, some forms of local treatment, including intraarterial chemotherapy. Now we have also added intravitreal chemotherapy, especially for vitreal seeds, etc. And a second teaching hospital has also started focal treatment. Intraarterial chemotherapy started in Ghana in April 2020 in partnership with a private hospital. We've had 3 children receiving 7 sessions, 2 Ghanaians and 1 Senegalese. They're all doing well. Thank God, the government hospital, that is the teaching hospital I work in, now has the infrastructure for this. And by the end of the year, it would have been fully established, and we'll now start doing this in the public hospital. So come 2022. We have also laid the foundation for ocular brachytherapy. After almost a year plus of working on permit to import, we now have a permit to import. And the training and implementation to start this service was delayed because of the COVID-19, but we are working towards starting this early 2022 in collaboration with Life Institute. Currently, this strategy has been incorporated in the next 5-year National Eye Care Policy document, and then also the Universal Health Coverage Policy for Ghana under childhood cancers up to 2030. And this is a major achievement for us. We recently, as mentioned, had a national stakeholders meeting, which was a mix up of virtual and on-site, where we revised and adopted a draft strategy, in which we are currently working on the final document for submission to the Ministry of Health so they can implement it. These are external partners have helped us in so many ways, in capacity building, in equipment acquisition, and in introduction of new services, and we are grateful to them. Establishment of a fund or an endowment fund and a foundation to help support our treatment is ongoing, with the legal aspect of it going through registration. A 7-member committee is in place. And I'm happy to announce that just yesterday, 4 major childhood cancers, including retinoblastoma, is now going to be covered fully. Its treatment, diagnosis and treatment going to be covered fully by the National Health Insurance Scheme. And this is good news to us, because until then, all costs were being borne out of pocket. Preparation of patient stories and advocacy through the media is ongoing to help us prepare and establish the foundation to fund other treatment that the NHIS may not cover, like IEC and brachytherapy. Patient and family engagements have been going on, and we give credit to the pediatric oncology group in my country, where these groups, patient and families engagements, are in the area of advocacy, counseling, and fundraising. And currently we have been working with them in this way. We just concluded collaborative research. We just concluded a baseline national survey on retinoblastoma, looking at the epidemiology, the clinical outcomes of our patient, and the referral pathways that exist. This was supported by Orbis International, and this actually informed the national stakeholder meeting that we held in August. And dissemination of the results will be done through publications in the coming year. For monitoring and evaluation, we have a multidisciplinary retinoblastoma care team established in my hospital. We participate in a pediatric tumor board in Kolebu, which is a bi-monthly meeting, and which brings together the multidisciplinary team to discuss conditions. The next steps are that we want to ensure that our referral pathways are clearly defined with dedicated hotlines and the use of the USSD code for frontline workers. We want to complete our treatment guidelines and SOPs, which we've started. We want to establish a registry for retinoblastoma, a national registry for retinoblastoma, which is actually being piloted now using the database that we use for the national survey. The foundation we are hoping will be established next year. We'll continue with capacity building, and above all, we'll start the full implementation of the national strategy, hopefully in 2022. In conclusion, the need to change the verdict from death to survival for retinoblastoma in Ghana is established now. The journey has started with modest gains. The time to escalate the national effort so that the verdict becomes survival and not death is now, and it's indeed gathering momentum. I want to thank you for giving us an opportunity to share our experience, and especially Emcc and all our external partners for helping us start this journey. And we are really working hard to let this dream come true, that our children will survive and not die. Thank you.
Thank you very much. So now Dr. Jambi, Dr. Jambi, are you here?
Yes, I'm here.
Okay, can you share your screen? Good, we see it, very good.
Good morning. It's afternoon in Kenya. It's a pleasure to be here. Thank you for inviting me to present on behalf of my colleague, Dr. Karaki Kimani, who is unable to join, and Dr. Mugambi, who is our interventional radiologist. I'm presenting on our first case of intraarterial chemotherapy for retinoblastoma child in Kenya. This is a child who was born in 2014 in April, TJ, and the right eye had been enucleated at a different facility. And we had the chance to look at the left eye on 17th of November, 2014. And these were the examination of an under anesthesia findings of the left eye. There was a big group B tumor covering the macula and mainly affecting the temporal part of the retina. So she underwent 6 courses of high-dose chemotherapy, and she got a fantastic response. This is how the eye looked with very good regression after the first cycles of chemotherapy, 6 cycles. After that, this was followed by several sessions of transpupillary thermotherapy using laser and she had very good response and control of the tumor. 1 year later, she started developing recurrences, mainly affecting the upper part of the tumor. And this has been going on for quite a number of years. And since 2016, she's had repeated recurrences. And every time she would get a recurrence, would combine systemic chemotherapy with focal therapy. And in between, she would get between 1 month to 2 months of control, followed by a recurrence. In November 2019, we tried to treat her with intravitreal chemotherapy, and there was some marginal response. On my left is how the tumor was before the intravitreal chemotherapy, and after 4 courses, there was some marginal response to chemotherapy. And on that note, we advised the parents on intraarterial chemotherapy because he had exhausted other options, or a referral to India. Referral to India was not possible for them because of the financial implications. But meanwhile, we continued with the systemic chemotherapy. And this resulted to severe bone marrow suppression to a point that she could not take any more systemic chemotherapy. So on 1st of March, in March 2021, she received her first intraarterial chemotherapy of melphalan on topotecan. And this was followed by 3-weekly transpapillary thermotherapy post-intraarterial chemotherapy. She had good response for about 4 months. Of note, it is only the upper part of the tumor that has been having recurrences. The lower part of the tumor got fast control after the first course of treatment and has never recurred. It is just the upper part of the tumor that gets repeated recurrences, as shown in the picture on the left. So in July, she was noted to develop a cataract and had a poor view of the retina, and the treatment and the response of the tumor was difficult to assess, and therefore she underwent cataract surgery with good outcome. But what was noted after the cataract surgery is that she had developed another recurrence, still at the same spot of the upper part of the tumor, and a second course of intraarterial chemotherapy of melphalan and topotecan was given. And of note that this child has had almost 7 years of globe salvage in the left eye, and with more than 30 cycles of systemic chemotherapy and quite a number of sessions of transpapillary thermotherapy. She had received 3 cycles of intravitreal chemotherapy and 2 sessions of intraarterial chemotherapy. Since up to last week, she was doing very well in school, and this is a picture of what she's able to do in school. She still had reasonably good vision, and as of last month, her vision was 3/21 using the layer chart. But unfortunately, after the second cycle of intraarterial chemotherapy, she got very good response, as you can see on the upper part of the tumor. It is very well controlled, but unfortunately, she was the vision has dropped to navigational vision for now. We continue to evaluate her and see whether the vision will come after the treatment, since it's just about 2 months after the second treatment. Thank you very much. That's the end of my presentation.
Thank you very much for this. So now the session is open for discussion and questions. So do we have questions from the audience? So there is a question from Professor Robert Lukamba on where they perform intraarterial chemotherapy in Africa. So you've just seen that it's possible in Kenya and also in Accra. So I think this answers the question. But we hope that it will also develop in other countries in the near future. So I have a question for Martin. Martin, can you tell us when the molecular biology will be available in the pathology lab of Dhaka?
It's for the second phase and the intermediate phase and the second phase. So it begins just now about cytogenetics and molecular genetics, but I think I let Makura Gaji to answer this question. I think that we are buying the probes for the fish technique, and for the molecular biology, I think that during 2022, and but some techniques are running. So I think it's just now, and let me begin. Makura, if you can say a few words about beginning of cytogenetics and molecular biology, please.
Okay, yeah. Thank you very much, Martin, and thank you for the question. We are really at the beginning, you know, as Martin said. The point is what I show you was done like in the last year, and it was done by money pocket, money pocket, you know, that my own money. Now with the foundation, we think it will be easy to increase what we are doing and put it on the table for patients. And that's why we are really comfortable to say that now, let's say in the next 3 to 4 months before the end of this first phase, we'll be able to really do all the cytogenetics and molecular and fish techniques for all the patients involved in this program. We are very confident on what we are doing because we have a long experience of that during our training. During our training as the PhD and as the master and PhD student. That's all what I can say. But now really, if you have some cytogenetics and molecular issue, we can discuss that and set it up in Dhaka and do it for you. No problem for that. Thank you.
Thank you very much, Makura.
Are there any other questions? Alexis, is Alexis there? Alexis Blono? Maybe they do not hear. Any other question from the audience? François, est-ce que les micros sont ouverts? Est-ce que les gens peuvent parler?
Les gens peuvent parler s'ils activent leur micro, parce qu'ils ont la possibilité de l'activer. Là, j'ai débloqué tous les micros.
D'accord.
Mais bon, il
y a pas mal de participants, mais ils ne sont pas très bavards. Sabine, je vois que Sabine est là. Sabine,
oui, je suis là.
Do you know if OMS is, as OMS, Alexis told us that OMS is recommending to improve palliative care in low and middle income countries. But do you know if there is action of OMS on this? Actions in governments or in Ministry of Health locally?
So what I can say, it's WHO 2 years ago asked us to translate documents in French because they wanted to increase the information and the pressure about the government, especially in Africa, to promote palliative care and pain control. So at the moment, WHO opened a large debate about palliative care in all the world, and there is action done for discussion and negotiation with health ministry in Africa. I don't know for the other continent, but yes, there is a strong action done for 2 years. It was quite a little bit difficult because of the pandemic this last year, but yes, there is action, and I will put on the forum Palliative the information we got from them.
Yeah, indeed, the pandemic has been a big problem for all cancer, but especially also cancer, children cancer. I have a question for Vera and Dr. Jambi. Can you tell us about influence of the pandemic of your retinoblastoma recruitment? Did you have problem with the pandemic to see the children in time? And is this improving now, or is it still a problem? Vera, can you tell us in Accra how it was?
Okay. We're looking at the attendance of children with retinoblastoma in our hospital. Surprisingly, the numbers were higher than the previous years that there was no COVID. So it tells us that the COVID was not actually impacting very much on their attendance. As you know, the periphery, we're now trying to organize a periphery. Our sister hospitals that also manage retinoblastoma to some extent, that is the teaching hospitals, are also increasingly seeing numbers. So I'll say that the pandemic has not actually impacted so much on the numbers. I think what is also encouraging them to come is the support funding, because WCC and Emcc to some extent provide some help to those who cannot afford. So transportation, the treatment, diagnosis, they get support. So that has also been encouraging them to come.
Yeah, okay. And in Kenya, how was it?
For us in Kenya, during the pandemic, we were markedly affected, and because of the curfews and the fear that came with COVID-19, and we had to get special passes for the patients to be able to access treatment. So that affected the numbers markedly. But now with the ease of the pandemic and the curfews, more people are able to access care. We somehow saw an advance of the disease and more advanced cases, but we hope as the pandemic gets controlled, this will return to normal. Thank you.
Thank you. Any other comment or questions?
Hello?
Yes?
I am Dikintum Josh from Cameroon. I am a personnel of the Cameroon Baptist Convention Health Services. I want to first of all appreciate the presenters for all the presentations that made value to me in this forum. Talking about Cameroon, the Cameroon Baptist Convention have bucket lymphoma programs that are funded by other countries worldwide. And that provides a window where the palliative care team lies on to provide pain control. Talking about it nationwide, I wouldn't be able to say it at a general picture, but I want to say that palliative care implementation in Cameroon started, but the progression is very slow because of several factors. Just in line with what Sabine said, I think we try to develop services, but the issue of morphine access, it started on well, but now it is actually blocked by policy, so much that we cannot have the desired powdered morphine, which will be constituted and served to patients at a more affordable rate or much free rate. So I'm just in that I want to think that there is still much to be done in Cameroon, because when you look at the map as presented by other presenters, you'll see that palliative care implementation is still very slow, and it's largely due to the poor access to morphine powder. So I think it is something we're learning a lot of lessons. We can appreciate how Ghana is progressing, and Kenya, like we've seen, and other big countries like Uganda. But I think that we still have a long way to go in Cameroon. And the Palliative Care Alliance that I've seen here, I think it is a very good lesson for us to learn and see how we can share in Cameroon. So I think that this was a very good opportunity for me to learn what other countries are doing and to also share a window of our challenges in Cameroon. Thank you.
Thank you. Any other comment or questions?
Good morning.
Good morning.
Okay, I'm Dile Isimoha. I am Technical Officer Cancer at WHO. So for the African region. So I just want to highlight one of the things that Sabine said about the documents for palliative care. Yes, with WHO, we are in the process to translate the documents in French. So French-speaking country will be will have the access of the tools for palliative care. And I also want to highlight that we have two initiative of cervical cancer and initiative of childhood cancer. The strategy for these two cancers. So this strategy those two strategies promote palliative care in Africa. So many countries that we are following, we are support for the promotion of palliative care. As in Burkina Faso, we are promoting the access of morphine syrup. We are in the project, and it's going on to have access of morphine syrup. And we have always support WHO, always even support palliative care training, as they have here in Burkina Faso, one university which want to provide a training in palliative care for healthcare, for medical doctor and paramedical and nurse, the others. So WHO support this university for the training. So it's what I want to highlight, that our region, we have many strategy, many commitment, a lot of commitment to promote the palliative care. Thank you, thank you for this great meeting. Very, very interesting presentation. Thank you for the invitation. Thank you.
Thank you. Thank you very much. Any other comment or questions? Yes, Robert, hello. You want to say something? I see. I can see your question
Hello.
on the chat. Hello.
Yes, yes. I wrote a question on the chat. I want to know if there is a palliative unit care in French-speaking countries.
There, Robert, I can just tell you if even we don't know exactly today the situation in all the French-speaking countries, I can tell you that in North Africa, as in Tunisia, where I have been, there is a palliative care unit, a proper palliative care unit. But as I know today, there is another, I will say, a starting palliative care unit in Douala in Cameroon with Dr. Esther Dinabel, but that's all that I know. If you want to see a properly palliative care unit with a few beds and all the pain control and training staff, it's still on the way, I think, in a few capitals in Africa, but not yet real clear and significant.
Thank you, Sabine. Okay. Any other question or comment? Okay, so I think we can conclude this webinar. And I want to say thank you to all the speakers, of course, and to all the participants for connecting with us. And I hope we can have other experience like this in the future. Thank you very much. Pierre, you want to say something? You want to?
No, just to thank every participant like you. Okay, thank you.
Thank you.
Thank you. Bye-bye.
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 Thank you.